All right, the next presentation is going to be focused on Jaspr. You've heard us mention Jaspr as part of our signature project, and we thought this would be a great opportunity to really dive deeper into what Jaspr is and to talk about our early lessons learned here at UMass with implementing Jaspr. So the first person to speak today is going to be Topher Jerome, and I will hand it over to Topher, and he will give an introduction, and then he's going to hand it over to Linda Dimeff, who will introduce herself, and then I and Basheer will end the presentation. All right, Topher.
Good morning, everybody. My name is Topher Jerome, and I'm a senior project director at UW Medicine's Harborview Behavioral Health Institute. I'll also say I'm a person in long-term recovery from substance use disorder and a multiple suicide attempt survivor. I've also lost 2 nieces to suicide in the past 5 years, so suicide is definitely an integral part of my story. I have way too much to say in the amount of time that I have, so I really want to focus on, I love Jaspr. I think it's a fantastic tool, and I've been involved. I formerly worked at Jaspr as the director of lived experience integration, and I worked in the doing a lot of the formative and part of the RCT as we were developing the app. So I've been in the ER, a lot of ERs, both as a patient and as a researcher. And I also, as a leader of peer support programs that I've developed that worked in emergency departments. You know, suicidal thinking has been part of my life since I was a teenager. I had a lot of trauma in my childhood. You can say I score very high on the ACEs. Yeah, I became addicted to drugs early on, like 11 years old, developed into IV meth use. I was 6 inpatient treatment centers, 9 outpatient treatment centers. It took me a really long time to get well. And every one of these times, I was just so ashamed of who I'd become. You know, I had this idea about who I wanted to be in the world, but it was just hopeless. I couldn't get there. And every relapse, it got worse. You know, one time I was hospitalized after a very serious suicide attempt. And in this, I had promised my family, who's very dear to me, that I wouldn't die by my own hand. But there I was again, years later, with a plan, the same plan I had before. I didn't know what to do. You know, went to the ER the first time that I actually walked in the doors on my own, and didn't know what to expect. I'm locked in a room, and I really wanted to kind of focus a little bit here on what it was like as a patient in the ER. You know, being locked in this room, I know the little square window with the wires, security wires through it, and gray walls, nothing, hard plastic, everything locked down, sitting on this bed with plastic on the, you know, and as the thin blanket. I loved Susan's reference to a heavy blanket. Nothing to do, and just, when do I get help? I came here for help. I was desperate, you know, and sitting there in my own head, it just got worse, you know, and it's like, why did I come here? And then people come in and they ask me the same questions over and over. And it's like, is anybody listening to me? Why are these people asking me all these questions? Repeatedly, right? It's just different forms of the same thing. You know, I had no idea what was going on. I had no idea who was coming in next. When was I going to get help? I wanted help. And the feelings of isolation, the deep shame, you know, this stuff was my drivers. And so being there just made it worse. The other thing that happened to me a lot, and this is really drives me crazy, is people talking down to me, talking to me like I was a child. You know, I was a meth addict. I had multiple suicide attempt survivors, you know, and people had there's stigma and that I was faced with, both my own, but also coming from the people who were there to help me. You know, years later, lots of work later, I know that the staff who were in the emergency department were doing the best that they could. It was about triage. It was about keeping patients safe. You all know this, right? Moving them on to the next thing. But I wasn't getting the, there was something missing. so anyway, years later, after other ER visits, inpatient stays, I eventually got better. More than 13 years clean and sober now, largely due to 12-step programs. And something happened in that process, which was this idea that there's this magic that happens when somebody shares their experience, that's something I've gone through, and it's this magic aha moment. It's like, oh my God, I'm not the only one, you know? And whether it's addiction or suicide, it's really poignant in the suicide, in my suicide story. And so I'm working at Jaspr, and we decide we're going to develop some videos of people who have lived experience like myself. And so part of my job was to find people to interview, doing the interviews, editing these videos, and then doing the formative research. So I'm in hospitals, a lot of them in the Midwest, um, and showing people these videos and showing people the early versions of Jaspr. And I just watched, it's like we were able to recreate that aha moment delivered through videos in the app, watching people nod and tear up and just like, oh my God. I remember this one kid, he was, you know, he was like somebody I thought he would have all kinds of judgment about what I was going to show him. And he got into it and he says, man, this is life-changing, and it's like, it just gives me goosebumps to think about it. Um, People saying, I didn't realize there were other people. And, when we work in and around these environments, we work in emergency departments, we are so desensitized to the struggle that people are going through. And that, there just needs to be more. It's like people come to the emergency department because they're desperate for help and they need more. And so developing Jaspr was this incredible project. It's like, look, here is something that's going to deliver, it's going to deliver some help, and it's something to do. People find hope in the shared stories. Linda's going to talk a lot more about Jaspr, but things to, so the psychoeducational skill building, the stability planning, which is, to talk a little bit about the stability plan. One thing about it that is, I'm a level 5 people pleaser, right? I know what to say. I know I'm a master at figuring out what people want me to say, saying it to get the results that I want. And so doing a stability plan on the app, and I heard this repeatedly from people, was like, it's this quiet time that they can be honest. They're not having to judge deal with the interface of a human. Not that the interface with a human is bad by any means. This is like an augmentation as a way, and it's not for everybody, but it's for a lot of people, but that they have the ability to really get honest. I had this one guy, I know I'm a little bit over here, just this one last story, but I was working with in the emergency department with the stability plan on Jaspr when we were developing it. And, he had these horrible hand tremors, right? And it was just, it took forever, but he diligently answered every single question. He'd type a couple letters and all these extra letters, and he would delete the thing. He went through this thing and it was agonizing to watch, but he was so engrossed in it. And I just love that. Anyway, obviously I believe in Jaspr. I think it's a really important tool, and I'm going to pass to Linda, who's going to get more into the details of the Jaspr app.
Thank you, Topher. I just have to say, one of the greatest pleasures and honor of my professional life truly is getting to work with Topher, learning from Topher, understanding the power of lived experience, and through Topher, all of your brilliance, your ability to help all of us understand how to make this thing really so powerful. So let me And thank you for your story, as always. So I think what I want to do is just kind of quickly go through a little bit, just so you have a framework for what it is, and then talk with you about the research, and then we'll have plenty of time for questions. So just to say, like, our goal was not to create anything new. It was simply to deliver expert recommended evidence-based suicide care. So rather than just waiting and waiting and waiting, and as Topher described, ruminating and ruminating and ruminating about like wanting to die by suicide and all the things that are going on in your life, like, could we give them things to do that were evidence-based? So that was our goal. And when we think about, okay, well, what are those things that are actually expert recommended for people who are acutely suicidal in the emergency department that we embedded? It was a comprehensive suicide risk assessment. So we began with CAMS. So for those of you familiar, it's the suicide status form. We transformed it into an interview that is super compassionately delivered by a chatbot. And you'll see a little example of this. Again, informed by CAMS, people create a safety plan. There's lethal means assessment within the tool. We're directly targeting stigma and instilling hope by many, like literally, thanks to Topher, hundreds of videos of real people with lived experience, not actors acting like people with lived experience. And then there's just a ton of behavioral skills from cognitive behavioral therapy and DBT, also taught by people with lived experience. So that's what we've crammed in. Now, in terms of just high level, again, our goal is not developing anything new, just delivering evidence-based suicide care with the goal of helping stabilize the patient. So rather than just assess and refer to inpatient, the idea is if you actually give people evidence-based suicide care, they will stabilize. And so how do you do that? So within the app, to help with this, project here, there's a section called Comfort and Skills. These are all videos that combine skills to distract, including watching puppies. A person can watch 10 minutes of puppies, literally as a way of getting their brain somewhere off their problems to help them become more emotionally regulated so they can better engage with their medical team. And then also behavioral skills, again, taught by people with lived experience. And then as Topher mentioned, because he created these, there's just hundreds of shared stories, and they're organized by theme. And I'll show you a little bit of what that looks like. Now, another feature, recognizing that people are at the highest risk for suicide, for death by suicide post-discharge, everything that they've created in the emergency department on the Jaspr tablet gets pulled into a mobile app that Topher was also heavily involved in designing, called Jaspr at Home.
Can I just say something really quick about the puppy?
Yeah.
I can't tell you how many times people go straight to puppies, and to watch somebody who's in distress start to laugh. It was crazy. I could not believe how popular that video was.
And effective at its goal, right, of helping people get regulated. So on the provider side, everything gets piped into, as someone mentioned earlier, Epic. And so you can pull up and see, the provider can easily see how the patient has responded in advance of going into the room, if this is how they choose to use the tool. But you can think of it as like having a really powerful technician who's able to gather a lot of information so that when you get in there with the client, you're actually able to use your precious time to go a little bit more deep and help them with their problems and figure out the most, helpful discharge disposition. So Topher mentioned this, but everything we have generated is built with people with lived experience. We do nothing in this tool that doesn't involve really deep engagement with people with lived experience. And then, of course, everything that can be taught by people with lived experience is taught. The way that the app begins is there's onboarding by Dave Jobs, who's obviously the treatment developer of the collaborative assessment and management of suicidality, paired with a person with lived experience, and Diana Cortez. And they are both welcoming the patient, acknowledging that they're glad they're there and orienting them to what the tool is all about. So this is just an example of for all aspects that involve gathering information, there is, it's not AI, that would not fly with the FDA, but there is a chatbot who's asking in a very compassionate way, questions to the person and then responding using branching based on the response to those questions. What's also very cool is there's, again, embedded throughout people with lived experience orienting the patient to why something matters. So in this case, you can see one of our people with lived experience who's on our advisory board, Ashley, describing why the safety plan actually matters. So it's not just me as a scientist and as a clinical psychologist speaking to that. It's actually people with lived experience. I'm aware of time. I just want to kind of go quickly and show you a couple of kind of high-level screenshots. So here you can see the shared stories on the left. So you can either search by a topic, and you can see all of the videos within that topic, or by a person. So if you find that there's just someone you really resonate with, maybe Topher, then you can just watch all of Topher's videos. Same with comfort and skills. All right, here's just to say we have lots of teen content too, which I feel great about, and also for families. Again, just in the interest of time, I'm going to advance a little bit. Here's a few screenshots of Jaspr at home and what that looks like. Again, everything is getting pulled from what the tablet that they use in the emergency department into their phone for later use. So let me just talk really briefly about our data to date. So we conducted a randomized control trial comparing Jaspr to Care as Usual at Mayo in Rochester and Allina Health in Minneapolis, and both with high commitments to doing evidence-based suicide care. So we had to discontinue the study before we were sufficiently powered because of COVID. We began our study in January of 2020, so just before COVID took over emergency departments in all of our lives. So what we were interested in really seeing, kind of our primary hypothesis, was that those who received Jaspr would actually be exposed to more evidence-based suicide care procedures than those without. And what you can see is that, in fact, 100% of the people in Jaspr built a safety plan in comparison to 12% in Care as Usual. 85% completed lethal means management in Jaspr versus 6% in Care as Usual. 93 identified having met with people with lived experience and being impacted by them versus 6% in Care as Usual. 93% learned behavioral skills. The average was 4 versus 12. 12%. And I should say this is after being in the emergency department for 18 hours. And then we also found differences pre-post between conditions that was statistically significant. That was all, by the way, statistically significant. We also found similar findings with agitation and distress. People in Jaspr were a lot more, they reduced significantly over time agitation and distress. Now, the other thing is this is actually a study that was done by Allina with 988 patients. What they found, they were particularly interested in looking at functional outcomes. So they found a significantly higher rate of discharge home from the emergency department, significantly more completion of safety planning, and their rates are fabulous. Like Care as Usual was still much higher than standard Care as Usual for safety planning in the emergency department. Care as Usual, 39% versus 76%. Again, this is a naturalistic study in a real world without the guardrails of a randomized control trial. So where the control condition was people eligible for Jaspr, but for whatever reason, they didn't receive it. There was a significant difference on episode restraint episodes favoring Jaspr. And they also found a similar finding where there was a significant reduction in agitation and distress. Just really quickly, we just published this study. This is of 962 people in 10 different emergency departments. And we were really just looking to see, to answer the question, is Jaspr safe? And, how is it being used? And do people like it? And honestly, this was really getting us ready for our FDA de novo application. So what we found is that there were no adverse events, that in fact, the most commonly prescribed modules were the comfort and skills and lethal means, because providers can decide which of the modules contained within Jaspr they choose to have their patient to use. We also found a significant reduction again in agitation and distress, and people really liked it. 84% to 89%, depending on the setting, recommended it for others in their shoes. Now, I want to just mention one more thing really quickly. So one way of knowing if something works is a randomized control trial, but there's another way, which is just like doing a fidelity checklist. Again, we weren't trying to create anything new. We were simply trying to determine, we simply wanted to make it possible for people to get evidence-based suicide care. So we did 2 studies that were really all about kind of looking more at the fidelity of Jaspr. Like, did it actually deliver evidence-based care as recommended by experts based on the components that you would expect to see from a fidelity or an adherence perspective? So study 1 is that we had to create kind of a checklist, which we call the Suicide Care Fidelity Checklist, that was based on and essentially identifying key performance elements for each of the domains covered in Jaspr. And so just super high level, 6 domains. We had subject matter experts, internationally recognized subject matter experts in each of the domains. They were blind to who also was engaged, was part of their kind of like rating group. And what they had to do, each of the domain experts, was figure out and get consensus on what were the key performance elements that had to be covered by that, like, in order to achieve fidelity. And this isn't just for Jaspr. This is like, if you're doing safety planning, given there's a million different ways that you can do safety planning, what are the key elements that experts in the area of safety planning are saying you must include in order to actually check the box that you've maintained fidelity? So what we found there, we created this checklist. It has 85 key performance elements. And of those, 66 were determined to be essential. Now, we did a second study then, taking that checklist, and then we had a group of independent raters rate whether or not those things showed up in Jaspr. Hopefully this is making sense. And what we found is that of those essential items, essentially 96% of them showed up in Jaspr. So Jaspr as a tool is consistent. It actually is consistent with best practice at the level of key performance elements. Ed, I'm almost done, I promise. So these are just some lessons that we've learned over time, and probably Topher has a list of his own. But what we know is that EHR integration really, really matters for adoption. And, it's because any extra step, any extra click just creates burden for staff. And that, even if it's like a small amount of friction, it will interfere with adoption. The other thing we found is the importance of strong leadership, like throughout the system, from the highest person to, opinion leaders and champions on the floor. Who can really make sure that whatever the barriers are to use get efficiently solved, and enthusiasm and motivation stays high. And also that we found that it's really helpful to have people on the ground who are champions help us co-design for an effective workflow. And really serve as super users. So rather than where they fully understand the intention, the function, how to use the tool, and they can help coworkers solve whatever barriers they may have. So I think with that, I will stop screen sharing. Topher, is there anything else before we pass that you want to mention?
No, I mean, well, I say no, and then I keep talking. With the stability plan, one of the things I really appreciate about it being linked to the at-home app is that, as they create the stability plan, they can choose videos that were meaningful and, add these things into sort of this dynamic living plan that then they have at home. And then they have the things that helped them in the emergency department or were meaningful for them that they discovered are there on their phone at home later. And I thought, I just kind of wanted to emphasize that. And then your last, on the last point on your last slide was, finding champions. I've done a lot of work implementing new programs, and it's really hard to do something new in an emergency department and psychiatric inpatient centers, and a lot of the work I've done is being integration of peer support programs. But what I have found is it is critical to have champions on the ground, and that if you get somebody who's a believer who can help move it and help sort of spread the enthusiasm. So I'm just nailing in your last point there. I think because it's hard. People are busy. This is hard stuff to change. It's hard to change your workflow. It's hard to think about how care is going to be different. And so it really is both top down and bottom up approach to actually getting the change to happen.
Thank you both so much. That was incredible. I love the blend of the science and the evidence base with the perspective of people with lived experience and an appreciation for the difficulty it is, even something new and innovative, and something that we really think can benefit our patients. The challenges that we have in terms of actually operationalizing it and getting it adopted, which is what we're going to segue into now, because what we're going to talk about is, if you hold on one second, I'll get to the slide. So we're going to talk today about the early lessons learned from our randomized controlled trial here at UMass. As I mentioned, we've enrolled around 60 patients here at UMass, and also our experience with the initial preparation and integration of Jaspr at Ohio State University Medical Center. There we go. All right, excellent. Thank you. So one of the major lessons learned, which seems like it's obvious here because the Jaspr software is made available on a tablet PC. So access to a tablet PC is necessary to be able to deliver the intervention. As we talked about earlier, and as Topher mentioned, and as Susan mentioned in our experiences, so access to tablet PCs are necessary, but if you think about it, when you've been in an emergency department recently, or if you've talked with people who have been treated in emergency departments, tablet PCs are typically not available for general use, and certainly not for people who are dealing with a psychiatric crisis and who might be suicidal. Protocols prevent access to personal digital devices, as we mentioned earlier. In most emergency departments, there's a fear that the tablets will be used, will be broken, they'll be stolen, or they'll be used as a weapon. And in milieu settings, in other words, settings where people are cohorted together in a common space rather than actually in an individual treatment area, having one person access a tablet PC or get some kind of access to anything and other people not getting access to it can cause interpersonal conflict between the individuals in that milieu setting. So these were all barriers that were surfaced early on in our work with our clinicians and administrators who work in the emergency department as concerns for why we might not be able to actually deploy Jaspr here. So what do we do to address these issues, or what can be done to address these issues? If you can move a patient to a private room. So currently in our psych ED, people are in a milieu setting, and that we are able to pull them into a private room when it's available. It's not always available, so that does reduce our ability to be able to actually deploy Jaspr effectively because there simply aren't enough private rooms. You could consider creating a station for Jaspr. So we had talked about this early. We didn't actually deploy this here, but it's something to consider because you might actually think about in some general treatment settings, you might be able to set up a station that is specifically devoted to having people engage with Jaspr, like in a chair with a table that has the tablet on it. So it wouldn't be within a treatment room, but it could be in a sort of a dedicated section. You will have to try to think about how you're going to change your policies and protocols to allow a tablet access. So if your hospital policy and protocol says people can't access any kind of digital health, you're going to have to change those policies and figure out exactly how this will be discussed with the patient, with the individual, so that they understand that accessing the tablet is a privilege, and that you provide the rationale and the expectations for what they can do on that tablet. The benefit of actually delivering a tablet rather than allowing people to have free access to their phones is that you can lock down what the tablet can access. It can access Jaspr, can access other sites, but the person might not, can be prevented from having access to the video, to the camera, et cetera. So if the hospital provides the tablet to the individual and it has the appropriate software on it, then it can actually end up being much better than the person's own phone, because you can actually steer them towards sites that might be helpful and prevent them from doing things like taking video of other people and posting into social media, which is a concern that if people have unlimited access to their phones, that might do that. Also, of course, you really need to make sure you put the tablet in a ruggedized case so that it doesn't get broken. And there are other mounting procedures. If you've seen telehealth carts, which have been really common since COVID, you can also think of mounting the tablet to a cart, which allows it to not be stolen as easily and can also help with it breaking. The second biggest barrier that we've faced is integrating Jaspr into the clinical workflow at a given site. There are general principles that are common across all emergency departments, but then there are going to be very specific workflow issues related to a given emergency department that are going to have to be navigated. So the ideal is to get Jaspr to the patient early in the visit for maximum benefit. As you saw how Linda presented the functions and the assessments, if you get that to the person early, then the information that the person delivers or provides in Jaspr can be delivered to the clinicians early so they can be prepared when they talk with the patient. Also, if you can deliver the interventional content early, it can help with reducing distress, reducing agitation, improving their ability to cope with their crisis earlier in the visit so that they're less likely to escalate. So early in the visit is generally a good idea, but the problem that you face in what we faced in our emergency department is that a patient may be in the psych ED for a short time before waiting for their evaluation. So they get called into our psych ED. They may not be in the psych ED long before they get evaluated. So that represents a very narrow window to try to be able to get people before they get evaluated if you're actually located in the psych ED portion of the ED. Because where are they? Why are they in the psych ED? Where they're in the waiting room. So a lot of our people who are being treated in our EDs get put in the waiting room first, even though they might have suicidal risk. They are in the hallway beds. They can be sent to the medical units, but cohorted in hallway beds, or they're in the milieu, the non-private setting that I mentioned earlier in EMH. So if you aren't able to approach a person or deploy the Jaspr in the waiting room or in the other places that people are before they get into your ED, it's going to be difficult to get the tablet to the patient earlier. You really don't want to delay clinical care. So especially when we're doing this in a research sort of a framework, but also obviously whenever you're doing it in a clinical framework, you don't want the delivery of Jaspr to actually delay the evaluation. So there's a really important principle there to try to get it to the person early enough so that they can receive benefit from it, but we don't want to delay the evaluation. The timing of the evaluation versus the reports that are generated are really important as well. So if the person is being evaluated by a behavioral health professional, and then you deliver Jaspr and you include all of the modules of Jaspr, you will get a risk assessment that was based off of CAMS as part of the report that comes in. But if the evaluation has already occurred and this report with this new information comes into Epic after the evaluation has been completed, that can pose a potential conflict between the information that Jaspr is delivering and the information that was obtained as part of the evaluation. And remember earlier, that's the reason why I asked this question of Susan, is because that could be an unintended consequence of the software. And it's important then for the clinician to be able to evaluate the new information that's coming in after their evaluation, reconcile it, and make sure that their medical decision-making is documented. And this is a significant issue. One way you can address this is, well, all of these workflow issues, of course, you really have to work closely with clinical management and clinical staff to design solutions that make sense for their clinical workflow. So you won't be able to do this kind of work unless you're actively engaged with people who are actually doing the work. They have to be on the implementation teams. They have to be consulted with regularly, and that's essential for any site. We're going to have to remain flexible. So I mentioned earlier about the timing of the reports. The good news is Jaspr anticipates this and allows you to not administer the risk assessment, but only the other intervention components alone. So you can administer the safety plan and the comfort and skills. You don't have to administer the risk assessment. And that might be a useful option for if the person's already been evaluated to be able to prevent this potential discrepancy between the risk assessment that's through Jaspr compared to their evaluation. So currently, when we enroll people in our psych emergency department, if they've already been evaluated, we simply don't check the risk assessment, and they don't get that part of it because the risk assessment was already done by a human being. Obviously, you're not going to roll this out and it's going to be everything's going to be fine right at first. You're going to have to iterate and adjust. So you roll it out, you identify a barrier, you solve the barrier, and you continue to iterate until the end result is something that actually works for the patient and works for the clinical system. The final issue that I'm going to address as a challenge is this medical legal risk fear. So this is endemic in emergency department. It's not just with behavioral health; it's also in the medical side as well. As you know, Susan mentioned, this fear is often generated based off of not accurate understanding or representation of what the real fear is, but it's the fear of being sued and of being held liable, even if it's a rare occasion. So, but this fear is real, and it drives a lot of decision making and drives a lot of the clinical work in an emergency department. So it's especially important to recognize that this patient-reported measure. So Jaspr is going to be pulling in a report that basically the patient provided. So it's an example of a patient-reported measure or patient-reported outcome. In emergency departments, this is really rare. It's a paradigm challenge because in outpatient, patient health questionnaire 9, other medical histories are often submitted by the patient. And the outpatient settings, they understand how to deal with this. But in the ED, it's a challenge. It's not really a common practice. And this is the first time, for example, in many EDs where a patient-reported measure enters the ED record. So that's a real paradigm shift. There's a concern that because of that, the reports might be missed. So remember earlier, Susan said, well, if you're going to administer an assessment, if you're going to collect information, the clinician should definitely need to know about it. They definitely need to review it and incorporate it into their treatment of the patient. So that's a given. We understand that that's the way it should happen. But if these reports are coming in and if they're being missed, then that can end up causing an obvious problem. The reports might come in after the evaluation. So remember, I talked earlier, the evaluation might happen, you deliver Jaspr, and then something comes into their record after the evaluation is complete. That's an even bigger problem in a workflow where once the evaluator is complete their evaluation, they move on to another patient and they no longer really are actively involved in that case. So there's no one really assigned to the case to be able to look at the new information that came into the record, which is makes it even more likely that the report might get missed. We mentioned earlier conveying contradictory information that might need to be reconciled, and people might include self-harm statements in their open text. So if they're writing open text, because the Jaspr asks them to do that, it's not all multiple choice. Then what if someone makes a direct statement of self-harm, like I'm going to go home and kill myself, and it's now documented in text, even in some places unlikely as a safety plan where that might be documented. So have we tried to address this? We've established clear protocols. So it's really important to make sure that whatever the team agrees upon, we document that in a protocol and a workflow, and that people get trained to do it, so that we don't miss these reports and that they can be incorporated into the clinical care. We also have to learn how to cue the clinicians that the reports are ready. So we've built some tools in our electronic health record to do that. We have a column, for example, on our track board. An ED track board is basically a view of all the patients in the ED listed in rows, and all kinds of information about the patient listed in columns. It's used heavily by people who work in the ED to kind of oversee where people are and make sure they're not missing anything. Well, we programmed a column that shows that there's a report in the EHR that's Jaspr, and they can click on that and go straight to the report. So we made it easy for them to find. And we also established other cues, for example, making sure that in the attending physician workflow, they use the area called the assessment. Basheer, do you remember the name, the workup tab? So if a report is available, it pops up in the workup tab to make it easy to see by the ED attending. Obviously, you have to resolve discrepancies per your usual practice. We talked earlier. Discrepancies happen all the time in emergency departments where you get different information, not only from different people, but also from the patient over time. So discrepancies in the clinical information is a common thing in the ED. And if that happens, it comes through Jaspr, then it would need to be resolved in the usual way, which means that the assessment would have to be maybe an additional assessment to clarify what's going on, and then to use that in the medical decision making. And to emphasize the importance of reviewing reports carefully and discussing with the patient to resolve. So Jaspr is not standalone. Jaspr is adjunctive and collaborative care. So it shouldn't be just looked at as a tool that the patient can use that doesn't need to be integrated into the actual care that you're providing for the patient. All right. Basheer is going to talk about some exemplar cases from our RCT here to illustrate Jaspr in use. I'll leave this here. That's 11:45.
Thank you, everybody. Good morning, and thank you for attending this session. I'm one of the project managers for Jaspr who oversee the day-to-day activities in enrolling patients in the randomized control trial here in our ED at University campus. And I'll take the next 5 to 10 minutes to tell the story of two patients who had a suicidal crisis that brought them to our emergency department. They agreed to be part of our randomized control trial. And spoiler alert, there is no special thing about these cases. They are typical patients who come to our ED in suicidal crisis, and I'm trying to show where Jaspr fits in the course of their ED encounter. The first case is about a 33-year-old gentleman with a past medical history of depression, PTSD, and then anxiety. He came to our ED with complaining about worsening depressive symptoms, and he had some suicidal ideation. These symptoms started the day before after hearing some bad news about loss of a family member. In his own word, he said, "My cousin passed away today. I felt really good yesterday, but life just slapped me in the face again." In our health system, we have universal suicidal screening. at triage, the nurse used the PSS-3 to screen for any suicidal risk, and we use the ED safe secondary screening to determine the level of risk. This patient screened positive at triage, and the level of risk was moderate. He was accordingly placed on a suicide order, including constant observation and safety check every 15 minutes. The patient didn't have any medical complaint. He was soon cleared by the ED physician, and then he was moved to the emergency mental health care area, waiting for the evaluation. During that waiting time, our research staff approached the patient, told the patient about the study, about Jaspr, and the patient showed interest in joining the study. We consented the patient accordingly. Linda before explained a lot about the patient interaction with Jaspr, all the coping skills and the videos that the patient can see. What I was trying to show here is what the clinicians see in their epic after the patients completed their interaction with Jaspr. This is from our Jaspr template that we received here in our electronic health record. First of all, it tells a little bit about the in situ risk. So it gives us information about the patient desire to kill self now. And the patient scored 3, which is consistent with what the triage screening was telling us. And then the note gives us more information about suicidal ideation, any plans, suicidal attempt, prior suicidal attempt. And it just worth mentioning that this patient stated one attempt before that the patient didn't mention to the ED physician. And that might tell me that, well, maybe patients are willing to share more information with a chat box compared to a regular interview with a provider. In addition to the regular questions that we ask during any suicidal assessment, we receive a list of the suicidal drives from the CAPES assessment, scored by the patients and ranked by the patients based on the importance. In addition, Jaspr note contains some other risk and protective factors, access of lethal means, substance use history, other issues like insomnia, loss in the family, relationship problems, any other health, physical or mental health problems. These are all cues for the behavioral health clinicians to initiate questions and ask the patients about these issues that the patients pointed out here. In addition to the assessment, the patient was able to generate a safety plan. It's self-generated safety plan. And as you can see, Jaspr helped through the different coping skills to, first of all, identify some warning signs, and then trying to help the patient establish some coping strategies that they can use. And of course, the patient was able to list locations, people, and professionals who can he access when they are in crisis. In addition to these standard 6 steps in Stanley Brown safety planning, the patient was able to list reasons for living. And he was asked about some scenarios for foreseeable events that might put the patient in crisis. And loss of a family member was one of the cases that the patient listed. Interestingly, he put that using the Jaspr application is one of the strategies that this patient would choose to deal with this crisis. Eventually, the EMH evaluation took place. They used the evidence-based standardized CSSRS for the evaluation. The patient was determined to be mild risk for community and negligible risk in situ. The plan was to discharge home and to refer the patients to partial hospitalization program. I want to review the timeline of this ED visit encounter with you. So the patient arrived to the emergency department on day 1 at around 8 p.m. Our research staff approached the patient around 7 a.m. the next day. We consented the patient, and then the patient started engaging with Jaspr. The patient finished the Jaspr assessment around 8:33. That's when the note was generated in the Epic electronic health system. And the patient continued to work on the safety plan that was received in Epic at 9:10. That safety plan, by the way, was auto-printed with the discharge paperwork and was delivered with the patient when they left the ED. And after the safety plan, the patient was able to continue engaging with Jaspr to explore the other coping skills. EMH evaluation didn't happen till next day, around 9:30 p.m., and shortly after, the patient was discharged. If you look at the timeline, there was around 25 hours between the patient's arrived to the ED and the patient got the emergency mental health evaluation. That's plenty of time where the patient is just sitting there waiting, don't have their electronics, probably in a hallway bed sometimes with constant light, constant noise, can't sleep. I would understand if the patient was agitated and distressed during that period of time. Now, we gave the patient Jaspr, and that was a way to distract the patient from and provide something useful, not only for the patient, but also for the clinical staff. We tried to measure this. So right after we consented the patient, we asked the patient on a scale of 0 to 10 about calmness, about distress, and about their ability to go home safe, and how satisfied about their treatment in the ED. And this was their answers. Then we gave the patient Jaspr. And after Jaspr, we asked the patient the same questions. Clearly, you can see that the patient feels more calm after completing Jaspr. The score went from 10 to 6. And even the distress went down. The patient was more confident that they might be safer to go home. And the satisfaction with ED care improved. Our engagement with this patient didn't end up by the patient going home. We are still following up with this patient for 12 months, according to the study protocol. So we are doing 5 follow-up phone calls at week 6, 12, 32, 6, 12, 24, 32, and 52 to make sure that the patients, to get more information if the patients return to the ED afterward or not. The second case is about a lady who is 43-year-old with past medical history of depression and opioid use disorder. She again presented to UMass with depressive symptoms and suicidal ideation. She was admitted in an inpatient behavioral unit the day before for 2 weeks, and she was recently discharged. She didn't feel that she is ready to go back to the community. She came here and she said, it's disappointment to wake up. I was discharged too soon. She wanted to make sure that she is fine. Again, this patient screened positive on the PSS. Her risk strata was moderate. She was medically clear. She didn't have any medical complaints. She was moved to EMH, and we enrolled her in the Jaspr study. If you look at the note for this patient, so the in situ risk is still consistent with what we got during the screening. It's still 3 on a scale of 1 to 5, right in the middle. The patient said, yes, I have suicidal ideation. Yes, I have a plan. And I have previous suicidal attempts. The EMH evaluation concluded that the patient has moderate suicide risk in the community and mild in situ, but the decision was to admit this patient to behavioral health unit. Again, I just want to review the timeline for this patient. The outcome is different. First patient went home, this patient went to inpatient unit. This patient arrived around 1:30 p.m. We consented the patient the day 2, next day, around 9:23. And then the patient started engaging with Jaspr, but there was interruption. The patients got tired. They wanted to have their breakfast, so we had to stop Jaspr engagement. And we came back to the patient later on after they got some sleep. And then we continued Jaspr assessment at around 1. We got the note for the assessment at around 1:40 and the safety plan at around 2 p.m. The patient didn't get their EMH evaluation till day 3 at 5 in the morning. And then they were transferred to behavioral health units at 11:45. Again, if you want to look at this timeline, there was plenty of time between the ED arrival and the EMH evaluation, which we use to enroll the patients. That's what we want to do, is to try to do it before the patient receive the behavioral health evaluation. But at the same time, there was around more than 6 hours after the evaluation until the patient got admitted in an inpatient unit. And this inpatient bed search sometimes takes hours, sometimes take days, based on how complicated the patient is, what type of insurance they have, and the availability of inpatient bed units, which caused this entire delay. This post-EMH evaluation period is another chance for Jaspr to be implemented. And that's what we are doing sometimes if the patients that we are approaching already got EMH evaluation. So as Linda mentioned, there are 3 components that Jaspr can be assigned: the suicide assessment, the coping skills and videos of people with lived experience, and the safety planning. So if the patient already had their EMH evaluation done, we can still assign them the coping skills and the safety planning. So the patients not only occupy this time, but they get some skills, and eventually when they get discharged, they get the Jaspr at Home app, which they can take away with them all these coping skills and the safety plan that they generated. I'm gonna give it back to Dr. Boudreaux and Linda, if you have any questions.
Thank you, Basheer. Thank you so much, Basheer. I think it's really great to be able to pull things together. You know, you had the whole story of the history of Jaspr, how it evolves, a lot of the research, the evidence base behind it. You've heard a story from people with lived experience. You heard our stories about some of the challenges that we had in actually implementing it. So that's system level stuff. And then you've heard stories about actual people, case studies that of people we've enrolled. So we hope that we provide a kind of a round and comprehensive look at Jaspr. We are at time, but I think we can extend it for 5 minutes to be able to answer. If there are any questions in the audience, come up and please ask at the microphone. Are there any questions on Zoom? Great. So the questions in Zoom have been answered by Linda already. So any, Susan?